And thank you for being here in this session. I feel very fortunate to be here today to share the work of the LSPCA in Malawi and what we're doing to control the spread of rabies. LSPCA is the oldest animal welfare organization in Malawi and actually pioneered mass rabies vaccination campaigns together with the government of Malawi 4 years ago. Dog population in Malawi is currently estimated based on ratios for this part of the world, so an urban ratio, a rural ratio. So Lilongwe has a current urban population of approximately 1 million people, and therefore an estimated dog population of approximately 47,000 dogs. And it's further estimated that 500 people die from rabies in our country every year. But rabies is largely unreported in our country, apart from vaccination drive data and data on post-exposure prophylactic vaccinations from hospitals. Systems or processes to collect confident data on rabies in dogs and people are not in place at the moment. And it's believed that many people die from rabies in Malawi without the correct diagnosis, as rabies can often be masked by other central nervous disorders such as meningitis or cerebral malaria. So the LSPCA supports the government to deliver mass rabies vaccination in the capital city of Lilongwe. In 2018, we vaccinated 37,881 dogs at 154 static points throughout the city. And we displayed messages of education material at all the vaccination sites. So while people were standing in a long queue waiting to be vaccinating their dogs, we took GARC education material, put these on pop-up banners, and people had time to look at them and ask questions as well. Our teams comprised of 30 vaccinators, handlers, and data recorders to do the vaccination drive over 40 weeks. This was the 4th vaccination drive that we'd done, so there were another 3 consecutive ones before. So during the mass rabies vaccination drives, a data collector was specifically tasked to collect data on all the dogs and the frequencies of vaccinations. As you can see, the number of vaccinations over the years, 2015, 2016, 2017, and 18, a very good increase in numbers every year. On the right hand, you can see the number of vaccinations broken down by 1st, 2nd, 3rd, 4th repeat vaccinations. We realized in 2018 that 42% of the dogs being vaccinated through the mass rabies vaccination campaigns were being brought for follow-up vaccinations. Over the 4 years of delivering these rabies vaccination campaigns, we advertised a toll-free number for the public to reach us through a rabies hotline. Initially, the number was frequently used just to find out where the static point is and when we're coming, and just to talk to people on the rabies hotline. So as time went by and the rabies hotline has been in place for a number of years now, people started developing more and more faith and trust in the LSPCA. They saw us returning year after year, delivering mass rabies vaccinations. And this call-in service was now used more often to ask for help and information on dog bites and problem dogs in communities. And another way of keeping in touch with the LSPCA was also using shop fronts to paint messages about dog population control, responsible dog ownership, and vaccination on shops where there's high commuter traffic on a daily basis, although in that picture there wasn't a lot. So moving on from monitoring our vaccination, because it's clear from the slides that I've just shown you that we were confident that we had reached at least 70 or 80% of our estimated dog population in the city, we still recorded very high numbers of positive dog rabies cases through our central vet lab. We also recorded through communication with hospitals that people were still dying from rabies. And this showed us that no matter that we had all this data from the health centers, we had data from mass rabies vaccination campaigns, data from the Central Veterinary Lab, and maps that I will show you in a minute that showed us where we had achieved our successes. We were still finding dogs with rabies, and we were still finding people and children, adults sadly dying from rabies. So, sorry, just maneuvering a different computer here. So community call-ins became more frequent as the trust developed, as the years went by, on the toll-free number, and we were getting a lot more reports on dog bite cases and problem dogs in areas. And we started doing map overlays to correlate dog bite cases, high dog population, and perceived free roaming dog populations to try and see where the problem was that we were not addressing and we were not getting to in time. So as I said, we were still missing vital information on the dogs who might carry the virus. Our post-exposure prophylaxis data from hospitals was not confident data. We had PEP is not always available at hospitals, and therefore that data used to report dog bite cases didn't correlate with the truth on the ground. So we were really in a false sense of achievement. So we needed two-way and near real-time traffic and communication to find and respond to cases of dogs with rabies. Government data shared quarterly or annually was not enough to find the dog, and that was still a very big question, a very big black hole in our rabies control program. So these are using map overlays that I showed you, that I spoke about earlier, to look at where rabies is in the city, where we do our vaccinations. So the red areas on the map on the left shows you the population density of dogs vaccinated. The map on the right shows you prevalence of dog bite cases in Lilongwe urban. Almost exact to where we see high dog density and where we have high dog bite cases. We were also very happy to see a buffer zone running through the center of the city, which could actually help us keep rabies in the different areas and not cross borders. Urban dogs are very territorial. So having analyzed the data on the maps, we were now able to focus on the high prevalence areas in Lilongwe and put our efforts where it is needed most. And moving away from mass rabies vaccination, this is what we looked at. We looked at the frequency of call-ins from the public. We looked at how to get regular data sharing between vet labs, hospitals, and the LSPCA rabies team. We looked at PEP administered to dog bite victims without actually confirming the case of rabies in the dog, which is a very high cost to our Ministry of Health. We also realized from our funding community that they were looking to solve a problem and not just tick boxes in terms of numbers and mass rabies vaccinations. So we conducted targeted active surveillance drives earlier this year to see what would come out of a change in approach. And we realized from this that rabies was still a major issue in the city. Within 6 weeks, we had 5 call-ins for suspected rabies cases. 4 of those 5 tested positive for rabies. In 4 weeks, in an area where we had already been delivering mass rabies vaccination campaigns. So, moving forward, community surveillance and response to an outbreak is really important. Communities live with dogs. Communities own dogs, they know their dogs, they know what's happening on the ground every day of them, every minute of the day. So if we could get in touch with them, we'd find the dogs that we need to look at. So we needed also to collect confident data on rabies to also inform the post-exposure prophylactic use in hospitals. Our country has very limited budgets, so we're also always juggling money between different departments to try and make things work. So remedial vaccinations were needed to follow up on the positive ID dogs in the areas where they lived. We needed a multi-stakeholder approach to get everybody together and start talking and planning, strategizing and budgeting. And we needed to look for a cost-effective and easy scale to to these solutions. So a One Health Rabies platform was set up in Malawi and is now working towards developing a national strategic plan. We will also be conducting a stepwise approach to rabies elimination, which Andre or Terence spoke to you about this morning. The Global Alliance for Rabies Control will support us in that. Another solution was to look at community-led surveillance and rabies action groups. So we've seen now in the last four or five results that we got that community surveillance is of utmost importance for us to find the reservoirs of rabies. Without these, they would have slipped off our radar. We wouldn't have known that this had happened, and we wouldn't have been able to find the dogs. So the local rabies action groups are volunteer groups that are made up out of traditional leaders, ward councillors, student councillors, care groups, a wide range of people that are really interested in safeguarding the areas that they live in. Another solution was to look at rabies data mapping and visualization. So data recording in our mass rabies vaccination drives were costly and time-consuming, using mobile phones and resources to operate. Visualization through creating the maps I showed you earlier on were time-consuming and costly too, and it needed very expert people to do those things for us. This was definitely not a scalable solution for the country. So now we use the GARC data logger that you saw earlier today to log vaccinations using GPS, and automatically we can upload it into an epi-bulletin. We have maps, we have visualization, and it can be shared across Ministry of Health, Vet Department, Ministry of Agriculture in an instant as soon as it's uploaded. So this is following on from the positive cases that I spoke to you earlier about. This is a map coming out of the DHIS2 that Terence spoke to you earlier on. Following on from a remedial vaccination in Lilongwe in the area. The red dot shows you where the positive rabies case was logged, and the blue and black dots show you the remedial vaccinations. We do, during the remedial vaccinations, pick up on all the dogs, not only own dogs, but also the dogs that we find roaming, living around the markets or taxi ranks. Everybody's included. This is just more a detailed map of this. I think Terence explained enough this morning about the platform, the community-based response and surveillance. So we track positive cases, dog bite cases, PEP cases, and vet-confirmed cases through a platform that GARC is developing called the Community-Based Response and Surveillance Platform. It's got multiple entry levels, and it also has multiple SMS or communication levels, so people can be informed from different areas across the city or across the country about what's happening and what actions need to be taken from that. Yes, so our solutions, the next steps in rabies control in Malawi is definitely moving on from 4 consecutive years of mass rabies vaccination campaigns, which were costly, data collection, which I didn't mention earlier on in the slide. Now with the GDL, we had to have one specific person collecting data during our mass rabies vaccination campaign. And it took about 3, 4, 5 minutes to collect the data for one dog. We can now vaccinate and log data on one animal within half a minute. So cost effectiveness of that is really important. So the next steps, as I said, moving forward now from 4 consecutive years of mass rabies vaccination, while we are still recording positive cases of rabies in the city, has led us to change pace, think out of the box, and try and find the reservoirs of rabies. So we will be working through community-based response and surveillance, which is based on the integrated bite case management approach. We will transition to continuous vaccination and the demand-driven vaccination by communities as they get used to seeing the importance of the work that they're doing and that they're contributing towards. And we will develop our One Health agenda on rabies for Malawi. Thank you.